good evening, everyone. I just want to start by saying, thank you for coming. I think you're going to have some great takeaways from this presentation tonight. I want to start by, you've heard about all of our esteemed staff of radiologists that we have here. I want to talk a little bit about the other staff, the staff that you see when you come to get your appointment for that screening mammogram or for that diagnostic or for that procedure. At my table over here to my right, my ladies in pink, those are some of my mammography technologists that you will see at any of the 3 locations that we have for screening or diagnostic mammograms. In addition, we also have a nursing team that could not be here with us tonight that actually will, be with you for any scheduling or procedural needs. And in addition to that, we also have our ancillary staff. We have 3 of them here today that is there for you when you call the breast center and you have questions, or you're just trying to get your report, or you're getting that wonderful phone call from our ray of sunshine for your callback mammogram. So I just want to have them stand up and just give them a little bit round of applause. Before they do, I forgot one person because she's sitting over there. Abby is our wonderful nurse navigator. She some of you know her very well, but she is also there for you in the event that you are diagnosed with breast cancer. She is there for you through and through to make sure you have all the resources possible, at your fingertips. I just want you to know that here at any of our breast cancer centers that we have here at Eisenhower, that you are in good hands. If you have to go through breast cancer treatment, we are here together for you. And you are not alone, and we are here with you. So at this time, I'm going to invite Dr. Sylvan up, and he is going to kick off our presentation.
Good evening. So first, before we start, I just want to say a couple of additional words about Dr. Starin. I literally could take the entire hour to introduce him. That's how many accolades he's had over the years. But let me just shorten it and say that he's had an illustrious academic career at a number of institutions as the head of surgery at various places. He comes to us most recently from the Arizona Cancer Center, where he was the chief there. And he is the former president of the American Society of Breast Surgeons. He is an MD, a PhD in immunology, and has his MBA. He is an incredibly impressive person and also one of the nicest guys you'll ever meet. So we are so happy to have him here. Okay, so I'm going to start talking about this first part of the talk. Dr. Elmi and I are going to do is really about screening for breast cancer. And I'm going to do a brief talk about screening mammography. She's going to cover all of the other modalities that we use. So first, I'm going to start with the randomized controlled trials. So it's interesting, a randomized controlled trial, I don't know if you're familiar with what they are, but they're actually very difficult to do. They take many years to usually prove what you're trying to prove or disprove. But basically, you're trying to control for as many variables as you can. And then in this case, women are randomized into 2 separate groups, identical arms. And one of those groups are women who are not invited to screen, and the other are women who are invited to screen. So I'll just start by saying that as far as showing mortality benefit, mammography is really the only imaging modality that really has randomized controlled trials to support it. The problem is these things are very difficult to do. Once you have another modality that you know anecdotally works quite well, it's very difficult to say to a woman, we're going to randomize you into this group that's not going to get that. And, it's just saying, these same problems go on with drug trials as well. I mean, you're randomizing people. You don't know. Maybe it works, maybe it doesn't work, and you randomize into 2 different groups. So this is, the difficulty with randomized controlled trials and with proving some of the things that we think we can prove, but it's difficult to do the trials. Anyway, that was kind of long-winded introduction, but going back to the 1950s and 60s, we became able to image the breast. So then the question was, well, does it do any good? Are there real benefits to it? Can we reduce mortality from breast cancer? So in the mid-1960s, a small randomized controlled trial was done in New York called the Health Insurance Plan of New York trial. And it was a pretty short trial for one of these kinds of studies. It was 5 years, but it showed a definite, more statistically significant mortality benefit from screening for breast cancer. So following this trial, there were 7 additional randomized controlled trials that were done. And all of them, as I said, involved randomizing women into these 2 identical arms. Overall, these trials showed between a 15 and 30% decreased mortality in women who were invited to screen. The largest trial with the longest follow-up period is the Swedish 2-county trial. And this has demonstrated a 63% mortality reduction in women who were actually screened and a 50% mortality reduction in women who were invited to screen. And so this distinction is a little bit confusing sometimes. So what happens is women are invited to screen. Some of them actually chose not to get screened. And some of those women who were not screened developed breast cancer and died from breast cancer, but nonetheless, they're counted in the group who was invited to screen. And so this is just statistical analysis. The flip side of it is that the women who were not invited to screen, some of them actually went out and got mammograms on their own and had a breast cancer detected, and that may have saved the woman's life, but nonetheless, she's counted in the not invited to screen group. What about women in their 40s? There's been some controversy about this over the years. Well, the randomized controlled trials showed that there's between a 15 and 35% mortality reduction screening mammography in women between the ages of 40 and 49. And this was on average 18 years of follow-up. So in 2018, Laszlo Tabar published an interesting paper looking at how screening affected the death rate from breast cancer. And this study showed that there was a 60% reduced mortality risk within 10 years of diagnosis amongst women who had been screened, and a 47% reduced mortality risk between years 11 and 20 after diagnosis amongst women who had been screened. So the question always comes up, when to screen and how frequently to screen. This bar graph has a lot of stuff on it, but we'll just focus on the 4 columns in the middle that are in red. The 2 in the left are women in their 40s, and the 2 on the right are women in their 50s. And this is looking at the life years lost to breast cancer based upon the age of diagnosis. And the take-home message from this bar graph is that the most life years lost to breast cancer are lost by women in their 40s. So what about the recommendations for screening? Well, there are a number of organizations, the American College of Radiology, Society of Breast Imaging, National Comprehensive Cancer Network, National Consortium of Breast Centers, and the American Society of Breast Surgeons all recommend annual screening beginning at age 40, and that screening should continue as long as health is good and life expectancy somewhere on the order of 5 to 10 years. I'll say a few words about the USPSTF, that's the United States Preventive Services Task Force. This organization gets a lot of press, and you may have heard recently that there was a change in the recommendations for screening that came from this organization. It's kind of an interesting group. It basically consists of 16 volunteers. They're all, very accomplished people, but it happens that none of them are experts in breast cancer. But they make the screening recommendations for breast cancer. They also make screening recommendations for prostate cancer, colon cancer, and other various kinds of cancer. But in this case, we're just talking about the breast cancer. So they made their first recommendation in 2002, and they recommended that screening should start at age 40 and should occur every 1 to 2 years and should continue through age 74. Then in 2009, they changed their recommendation and decided that screening should start at age 50 instead of age 40. And this is where a lot of this controversy came from, about women asking, when should I start screening? But they came out and said it should be at age 50 and that it should be every other year. So every 2 years at age 50. And then in 2016, they reiterated that same recommendation that screening should start at age 50. Prior to that, if you're younger than that, it becomes an individual decision whether you want to screen or not. But as an organization, they were recommending screening to start at age 50. And then just a few months ago, they actually changed their recommendation and went back to where they were in 2002 and said that screening should begin starting at age 40. Now they say that it should be every other year. they basically said that there's not enough data for them to make a recommendation as far as annual versus biennial screening. And they recommend that screening continue through age 74. And again, they just say that there's not enough data for them to make a recommendation beyond age 74. The American Cancer Society has kind of a hybrid opinion. You know, they say that screening should start at 45 with the option to start at age 40, should be annual from 45 to 54 and every other year after that. And American College of Obstetrics and Gynecology say that it should be offered starting at 40, but should definitely start by 50 and can be annual or biennial. I suspect that these two latter organizations, now that the USPSTF has changed its recommendation and every other body out there is recommending screening to begin at age 40, that it's likely that they will do the same, in my opinion. Just a few words about 3D mammography, because it gets a lot of press. Does it help? Well, the studies have been done, and there's an increased cancer detection rate of between 1.2 and 2.5 per 1,000 women screened. So that may not sound like a lot, but when we screen an average population, you know, we find on the order of 5 or 6 cancers per 1,000 women screened. So this represents, you know, a 20 to 40% increase in cancer detection. And it results in both an increased cancer detection rate and a decreased recall rate in women with both dense and fatty breasts. So I'm going to stop here and turn this over to Dr. Elmi. I'll just say a couple of additional words about Dr. Elmi, who you've already heard about. She actually did a research fellowship at Harvard for 2 years. And as you all know, our cancer center here is affiliated with UCSD. Dr. Elmi is actually an assistant professor of radiology at UCSD. We're very fortunate to have her here with us 4 days a week, and she's at UCSD 1 day a week. So Ozzy, come on up.
Okay, now that we kind of have established that a screening mammogram is one of the most effective screening technique that can improve life by about, decrease the mortality by 30 to 60%, is one of the best things we can do if we want to do screen as a woman for improving our life. Let's see what are the other options we have if we have a lot of risk, if we have dense breast tissue, if we have family history, if we have prior history of breast cancer. Is a screening mammogram as is enough, or we need more modalities to help us go through that? So I'm going to mostly focus on dense breast tissue. The reason for that is a lot of you, when you do your mammogram, you hear about it. We get that question all the time. What should I do if I have dense breast tissue? So I'm going to give you a little bit of background. What does that mean, having a dense breast tissue? And then we'll talk what to do if we have that. So to understand the dense breast tissue, I want to just kind of introduce you to the anatomy of breast. Your breast can be made of different composition of fat versus gland and ducts. So if a breast is made mostly from fat, so as is this breast, and that's how the mammogram will look like. What it means is mostly fat, as you can see at this gray darkish area in mammogram, and it would have only a little bit of paraglandular tissue or breast tissue. So as you can see, it's much easier to see through the tissue, is much easier to call an abnormal finding on it. As the breast gets denser, we would have more and more of the paraglandular tissue and less of the fat in that. And if someone has what, as we call them, extremely dense breast tissue, as you can see, almost the whole breast is white out, and there's not much intervening fat between that paraglandular tissue. So some patients would get concerned when we tell them your breast is dense. They're afraid if this is a problem, is the disease. I want to just share with you this diagram, which shows that almost 50%, half of the women in the US actually have dense breast tissue. So it's very normal. Most of us are there. So it's not a problem if we have dense breast tissue. We just need to know and then act based on that information. And then I want to just say about 10% of women in the US actually have that extremely dense breast tissue, the one that was all white out, and we'll see why that is important. So the next question is, some women don't know if they have dense breast tissue or not. They will ask, how would I know? So in California and most states in the US, we are obliged by the law to send you a letter giving you the result of your scan, and also say if you're a dense or non-dense breast. So I put just the letter that you would get from Eisenhower if you have a screening mammogram or study with us. So first it would start, what was your result? No, normal, abnormal. And then it will give you some, a paragraph about the density. And basically, if you have dense breast tissue, it would say that you have a dense breast tissue. So that's the way for you to know if you have dense breast tissue, basically. So now let's see what's the importance, why it's important for us to know if we have dense breast tissue or not. So if we take a person who has a fatty, very fatty breast tissue, if we think of the risk for breast cancer as 1, a person who has very dense breast tissue, the risk would be about 4. So they have a 4-time higher risk for developing breast cancer. And the reason for that is kind of easy to understand. Imagine the fibroglandular tissue is the part that actually develops cancer in it. So if you have more of that fibroglandular tissue, you're more prone to get breast cancer based on the density in your breast. And rest of the woman kind of would lie between that risk, depending on the density and the other risk factors that they might have. Another problem with having a dense breast tissue is the limitation of mammogram for finding cancer in that dense breast tissue. So cancer would look like that white stuff that you see on the dense breast tissue. So if you have dense breast tissue and the cancer, sometimes it would be really hard for us to see through that density of your breast to pick up that cancer. So I put just a sample of a fatty or fatty breast tissue, and you can easily see that dense small cancer in the middle of that. And it's easy to, for us as radiologists, or even someone that's not trained as a radiologist, to pick up that as an abnormal finding. But when you look at that extremely dense breast tissue, that is a lot of white things going on, it would be sometimes hard to pick on that cancer. So it would happen probably a few years there till for us to be able to see all those indentation and abnormal finding through the dense breast tissue and be able to pick it up. That's kind of the challenge for us as radiologists, and the problem for the patient, that it might delay the diagnosis of breast cancer. So now let's see what we can do. Now that you know that you have dense breast tissue, let's see what are the options for you, what you can ask your doctor to order for you. So we kind of have 4 or 5 modalities to help us see through that dense breast tissue. The most common one is the tomosynthesis, or the 3D mammogram that Dr. Sylvan talked about. I want to just show quickly why it's different than the conventional 2D mammogram. The 2D mammogram would be like a picture that you would just snap with your phone, just one dimension. It just shows the breast tissue as is. But the 3D would take picture of your breast at different angle, kind of similar to CAT scan, kind of. So we can see through the breast tissue from different angles. So if there is a mass hiding behind your dense tissue, would have higher chance for seeing it through that density. So as Dr. Sylvan said, it would help us pick up 1 or more 2 cancers per 1,000, but the problem still exists when someone has very dense breast tissue, because it's an X-ray technique. It would have the same problem as a 2D mammogram. So here's an example, someone with a denser breast tissue, not much you might be able to pick on the 2D mammogram, but on 3D, when we are scrolling through the 3D images, easily we can see this speculated irregular mass picking through the dense breast tissue. So that's how we can, pick this cancer at the earliest stage compared to the old conventional 2D mammogram. The other technique that is very commonly available is ultrasound. So the good thing with ultrasound is almost every center has that and can offer it to you. It can help us pick another 2 or 3 cancer in every 1,000, which is a great help. And especially if we add it to the tomosynthesis, it would help us, increase our cancer detection rate. The main problem with ultrasound that we are not offering it for everyone is the fact that it's very time consuming. Scanning both breasts for everyone is very time consuming. And at the same time has a lot of false positive, meaning that it would pick on a lot of like little dead cells and masses in the breast that might be benign, but there's no way for us to know if it's benign or it's cancer. And we end up doing a lot of follow-ups or biopsies in the patients. The other technology is MRI. MRI is kind of our big gun in breast imaging, is as we call it, our gold standard in breast imaging. It has the highest sensitivity. It helps us pick the highest number of cancer. So our sensitivity almost approaches 100%, 95, 97%. So we can pick about 16 cancer in every 1,000 patient, which is almost more than double the amount that you would get with mammogram. It has no radiation, so it's great. But the problem with MRI is costing. Not every center has it, or they don't have it enough to offer to everyone, or almost that 50% of the women that we talked about. And a lot of patients don't like it. It's not the nicest experience. You're lying on that tunnel if you had it, and you may hear some noise. If you're claustrophobic, just forget about it. So there are problems with MRI. So that's why we've been looking into in the breast imaging community to come up with another technique that has contrast on it, but would be easier to offer to the patient, easier for the patient to accept it. And that has come down to finding contrast-enhanced mammography. That's a newer technology in breast imaging that you might not have heard of it because it's more upcoming in the field of breast imaging. And more and more centers are now adopting it. At Eisenhower, we've been very lucky to have that technology very early on, thanks to our generous donors. And we've been one of the very few centers in Southern California to be able to offer it to our patient. So what contrast-enhanced mammography does is basically doing a mammogram and then injecting a contrast as you would do an MRI, and then doing a mammogram immediately after. So this way we'll get the information you would get from mammogram. You see the structures, calcification, masses, but at the same time, because you have the contrast on board, you'll be able to pick tiny little cancers that would have been otherwise hidden behind your dense breast tissue or the places that are hard to see on mammogram. So it is increasing the detection by almost 30-40% more than the regular mammogram and approaching to that of MRI. The problem is it has radiation because it's a mammographic technique, but the really good thing about it is very easy for the patient. The patient loves the experience, and it's easy for the centers to kind of convert from the mammogram to the contrast-enhanced mammography. One caveat about it that we have not been offering it to everyone so far is that there was no biopsy unit for them available before. So when you find something, you have to go hunt for them on the MRI or ultrasound or follow them. But the good news is in the past year or two, there's now biopsy unit available for contrast-enhanced mammography. So if we see something, we can biopsy. And here we are in the process of hopefully getting the fund through our generous donors. And hopefully we should be able to get the biopsy unit. And that way we can kind of open the door for more routine screening for a lot of dense breast tissue and the patient who have family history or personal history of breast cancer. So now that we've gone through these modalities, let's see, what should we do? What's the practical guideline for us? Unfortunately, there is no clear guideline through the literature. I try to put different things together to make it kind of easy for you to understand and kind of easy for you to pick based on your own risk. So if you don't have a dense breast tissue on your mammogram and you don't have any family history of breast cancer, typically that general recommendation that Dr. Sylvan talked about, annual mammogram is starting at 40 and continuing every year should be enough for you and would have a great performance for detecting early breast cancer. If you have a non-dense or fatty breast tissue, but you have some family history of breast cancer, then at that point, I would recommend for you to talk to your doctor, get a risk assessment. So we have free online tools that are out there that your doctors, your GYN, or even primary care can use and kind of put the numbers for your risk, personal risk there, and then come up with your personal risk to see how much of risk of breast cancer you have compared to an average woman. If your risk is going to be higher, then we would recommend for you to get your annual mammogram, and on top of that, getting an option for doing a screening MRI if you're at a higher risk for breast cancer. If you have dense breast tissue, it would be a little bit different. So if you have dense breast tissue and no family history of breast cancer, because your dense breast tissue already puts you at higher risk, makes it difficult for us to read through, we recommend for you to getting every year mammogram, and on top of that, probably ultrasound every year. If you have the dense breast tissue and family history of breast cancer, again, you gotta talk to your doctor about your risk assessment. If your risk is putting you at higher risk, you will get the mammogram every year, and then you can have a different form of supplemental screening that probably is better to have some contrast on board, meaning it should be either contrast-enhanced mammography or MRI along with your mammogram. And in order to get the benefits of different technology, we usually recommend the patient kind of mix and match things. For example, we can do mammogram and MRI this year and maybe mammogram and ultrasound next year, if you have just, average or slightly high risk. And then that way you would get benefits of both worlds, and then that would increase our cancer detection. So the last slide would be on the people that have personal history of breast cancer. If you had breast cancer before, has been cured, now what should you do? Should you do just routine screening as every woman, or should do it differently? So having a personal history of breast cancer would put you itself at increased risk for developing future breast cancer. So if you have dense breast tissue, we would recommend for you doing the annual mammogram, and on top of that, doing MRI or contrast enhanced mammography. So we would recommend just having something with contrast again on board to help us see through that dense breast tissue. If you do not have any dense breast tissue, and if you don't have, you have dense breast, you do not have dense breast tissue, and you were diagnosed after age 50, nothing else that other than the normal screening mammogram needed. But if you were diagnosed before the age of 50, then you would need, again, that supplemental screening, preferably with MRI or contrast enhanced mammography. Okay, so that's about it for the screening. If there is any question regarding screening from me or Dr. Sylvan or from Dr. Saponaro, go ahead. So that's exactly this slide, if you are a cancer survivor, we would go to your age of diagnosis. If you were diagnosed before age of 50, definitely you will need that supplemental screening, meaning that mammogram plus MRI or contrast enhanced mammography. Oh, other cancers. So no, other cancers, if it's ovarian cancers, we would recommend for you to talk to your doctor about risk assessment, because some genes that would lead to some cancers can also increase your risk for breast cancer. If you had any radiation to your chest due to prior cancers, again, we want you to discuss it with your doctor. But if it's not any of these two groups, you can have just age dependent and breast density dependent screening, and depending on your family history, like other people. So that's actually a very good question. I mean, especially like if someone had like bilateral mastectomy, would have the same question. That's actually a good question with Dr. Starr, because that's always a challenge between us and the surgeon. If you have the other breast lab, so the recommendation that is for the other breast would hold for both, especially MRI. If you're doing MRI or contrast enhanced mammography, we can do it in both sides. MRI is always bilateral, so there's no way for us to do only one breast. When you're going, it's just given for both breasts. So if you do MRI, it will be bilateral. For the mammogram part, it just comes down to the decision by the surgeon and oncologist. If on the exam they feel like you still have some residual tissue, they might want you to do mammogram on top of that ultrasound or MRI. If they feel like you don't have enough tissue, you don't have enough tissue for us to image, or no tissue for them to be concerned of returning cancer, then you don't need any extra screening. So Dr. Starr probably can pitch on that more. He's a surgeon. Yeah, so if you had bilateral mastectomy, we really congratulate you on being an amazing thriver and survivor. That's a very good question for your doctor, because so far as you saw on all the recommendation, everyone say after age 74, discuss with your doctor, personalized medicine, personalized, risk assessment. Actually, I'm doing a study. I'm done with the data collection, and I'm just almost ready to present it. So because here we have a very unique population at Desert, we have older population, healthier population compared to general community. What I noticed was that UCSC, which I practice, so I rarely see patient over age 80 to come for screening, but here most of our patients are actually 75 and older, 80 and older, 89, 92, 94. So, and actually patients wants to do it, wants to do screening, wants to have diagnosis of cancer, wants to get treatment. They're healthy there, but I'm telling them, an 89-year-old, when are you going to come for biopsy? She's looking at a calendar for her tennis tournament, so not to intervene. So that means this person, is healthy, needs to live longer. So that was the question that I had, and then that actually turned out a research project. I reviewed more than 60,000 mammograms here at UCSC, and to see what are the guidelines, what can we do for this older population that have been overlooked, their survival have been overlooked in other studies, maybe because they don't get screening as often. So hopefully that result will be out very soon, and I'm hoping that would really help to change the guidelines, because the guidelines are not looking into the aging population of the country, and overall, people are healthier. Now they're projecting that people are going to age to 110, 120 very soon. So there's a lot of a study going on in the field of longevity. So that's really a good question. No one exactly know, but if you have bilateral mastectomy, probably exam should be good for you. And if your doctor has any concern, always can send you for more imaging.
I had mammograms every year from the time I was 40 till 89, and it was found at 89, and it was a more aggressive
Oh, wow.
more aggressive cancer this time. So that's what, and I've been told by two different doctors. One says I should have mammograms. The other says I don't need them anymore. So I'm a little confused.
very gray
At my
area, as
age,
I
I don't
said.
know. I
You
don't
know,
know. I don't know if
you'll-
I do anything anyway at my age, but I just kind of wondered.
One of the issues is that, frequently there's not enough tissue to push back, to push the implant back away. And so you can't see a whole lot. So an intermediate way to look at this, if you want to have additional imaging, and we not infrequently see women like this with bilateral mastectomies who are sent for ultrasound. So it actually can be in many ways more useful than a mammogram. You don't, I see. Well, but even in that case, though, then if you don't have implants, if there's not enough tissue really to pull out an image, ultrasound, if you want to image, ultrasound is probably a better way to go.
Okay. Thank you. Sure.
I just want to say one other thing is because everything Dr. Elmi was talking about was related to risk factors for breast cancer. And we are in the process of establishing a high-risk breast clinic here. So one of the things that you need to know is what is your risk? And so that's information that actually can be obtained because we're affiliated with UCSD. We work with the UCSD genetic counselors. And so if you think you fall into a high-risk group, you would be able to be seen by our high-risk breast clinic. We were waiting for Dr. Starin and then Dr. Volchi is our new breast oncologist in order to start this, and they're both here now. So this should be starting in the near future. And so a lot of the decision-making will be based upon what your lifetime risk is for breast cancer.
Okay, so we're going to have Dr. Sylvan come back up and move on to the next portion.
I didn't really want to come up here twice tonight. We actually have 4 breast imagers at our breast center, and Dr. Ken Thompson is the 4th, but unfortunately he had a prior commitment tonight and wasn't able to be here. So I got his topic. So now we've moved on from screening, and the question is, okay, you feel a lump in your breast, or you have discharge from your nipple, or you have breast pain. What should I do? So breast pain. Oh, I can't tell you how many patients we see with breast pain. It's probably the most common complaint that we get in the breast center. And unfortunately, more often than not, we don't find a good explanation for it. So breast cancer doesn't frequently present with breast pain, but never say never. Occasionally it can. Is the pain diffuse within one breast or within both breasts? Are there any skin changes, redness, or warmth to suggest that there may be an infection like a cellulitis or a mastitis? But the pain that we pay most attention to is unilateral focal breast pain. So how to evaluate it? So generally we start with ultrasound. If a mammogram hasn't been done recently, may get a mammogram as well. MRI is not in general an indication for breast pain, but in certain select cases, if there's persistent unilateral focal pain that's unexplained and that's of significant concern to the patient and her doctor, we will do an MRI. And I'd be lying if I said that we haven't found breast cancers like that, because we have. Nipple discharge is a little bit of a complicated subject. There's both physiologic nipple discharge and pathologic nipple discharge. So the physiologic, which is somewhat normal, tends to be yellow, green, or white. Typically, it's bilateral. It's not spontaneous. It requires squeezing the breast to get material to come out. And if you look around the areola, around the nipple, you'll see that the material that comes out is usually coming out from multiple ducts, not just from one spot. Many women can express discharge throughout their reproductive years. Galactorrhea is a milky discharge from the breast. It may occur for a year or longer after lactation has ceased. Elevated levels of prolactin in the blood can cause galactorrhea, and there are some medications that are associated with this, such as antidepressants, antipsychotics, and oral contraceptives. If somebody has galactorrhea, so milky nipple discharge, and it's associated with cessation of normal menstrual periods, That's a significant symptom and suggests that there could be a pituitary adenoma, and that requires a brain MRI to evaluate. Duct ectasia is dilatation of the ducts. The discharge tends to be thick and creamy, can be off-white, gray, green, or brown in color. And in lactation, the ducts can become blocked, and this can lead to mastitis and infection of the breast, or even to an abscess formation. And those abscesses usually require drainage. Pathologic nipple discharge tends to be unilateral and spontaneous. It's coming out of one duct. It's usually clear or bloody, and the risk of cancer increases with age. So in women under 40, about 3% of those women present with nipple discharge, but over the age of 60, up to 32% of the patients have at least nipple discharge as one of the associated symptoms. Any discharge associated with a palpable mass or nipple inversion must be evaluated, and in males, nipple discharge is always abnormal. So pathologic nipple discharge does not mean that you have cancer. Overall, only about 5 to 15% of women who present with pathologic nipple discharge have cancer. So papillomas are the most common cause. They're about 32 to 60% of cases of nipple discharge are associated with papillomas. These can be a solitary intraductal papilloma, or there can be multiple peripheral papillomas. Papillomas that are associated with nipple discharge are usually excised. And if a biopsy is done, like a needle biopsy, and we find atypical cells associated with the papilloma, when those always get surgically excised, and there's a very high upgrade rate to cancer with those. So between 20 and almost 40% of those papillomas with atypia turn out to be cancer. Asymptomatic papillomas without atypia is somewhat more controversial. So if we do a needle biopsy and we find incidentally a papilloma on a biopsy, there's no associated nipple discharge and no other symptoms, it's somewhat controversial what to do about those. Here, most of them still get excised. Unfortunately, there's still a significant upgrade rate, almost up to 12% in some studies with asymptomatic papillomas without atypia. So in general, they get excised, but it's somewhat questionable. Duct ectasia, we talked about dilated ducts behind the nipple. This is the second most common cause of nipple discharge, 17 to 36% of cases. As I said, overall, cancer is found in between 5 and 15% of women who present with pathologic nipple discharge, and about 12% of patients who have DCIS, which is ductal carcinoma in situ stage 0 cancer, present with nipple discharge. But what about the evaluation? So in general, these women are going to get a mammogram and an ultrasound, and we focus particularly in the area behind the nipple to look at the ducts and to see if we can see small masses in the ducts. The sensitivity of ultrasound in detecting malignancy is quite high, somewhere in the range of 50 to 80%. I'll say a couple of words about galactograms or ductograms. We generally don't do these any longer. This is a test that involves injecting a very small amount of dye into the duct that's having the discharge and looking to see if we can find a lesion there. And while it's a reasonably good test at identifying lesions, it's not very good at, it doesn't do anything to differentiate benign from malignant lesions in the duct, and a negative ductogram doesn't exclude malignancy. So this test has largely been replaced by MRI. MRI has a very high sensitivity for finding cancer when it's there, and a very high negative predictive value. So if the MRI is negative, it usually truly is negative. And MRI, even though people don't like MRI, they prefer it over ductograms. It's not a fun test. Finally, I'm just going to talk briefly about palpable masses. Any new palpable mass needs to be evaluated. This is hard in women who know that they have cysts and they have lots of lumps in their breasts and they feel things all the time. But unfortunately, you can't make the assumption that a new palpable mass is just another cyst, so it needs to be evaluated at least with an ultrasound. We do mammography when necessary for palpable masses, and often if the patient hasn't had a recent mammogram, but most of the time the patients will get both a mammogram and an ultrasound. And again, while MRI is not a routine recommendation for palpable mass, if we have an unexplained palpable mass that we don't find anything on ultrasound or mammogram, but there's clearly a mass there, we'll often go to MRI, and it can be very helpful in finding this for us. So I'm going to stop here and introduce Dr. Saponaro, Dr. Saponaro, as you've already heard about, where he did his training. He has been here at Eisenhower Breast Center longer than any of us. He is the backbone of the place, and a lot of the changes and improvements that we've made over the years are thanks to Dr. Saponaro.
All righty. My talk is about what happens next. Once you've had a diagnosis of a mass, we have to find out what it is, and the next step is to do a breast biopsy. So how did I get here, and what do I do now? I'd first like to thank Danielle and our team. None of this happens without them. This is our radiology team that we've already spoken of, and we work as an integrated team. We're in some ways interchangeable, and if one person starts something, another person can finish it if necessary. So why did the radiologist recommend that I get a breast biopsy? Well, your mind is reeling, you have a lot of stress, and you're like, what's going to happen to me next? Rest assured that at the breast center, we have lots of support services, and we are going to walk you through the entire process one step at a time. And we're there to answer all your questions as they arise. So maybe you had an abnormal mammogram and that led to your biopsy. We've already talked about how and why we do mammograms. You had an ultrasound, which found a mass or some other abnormality. Then you end up getting a biopsy. You had a breast MRI, and that found an abnormality that requires a biopsy. Just because you get a biopsy doesn't mean it's cancer. But in this case, this is what a cancer looks like on a mammogram. This is what it looks like on an ultrasound. And down here on the right, that's what a cancer looks like on an MRI. So those are obvious examples. And when we see that, we have to biopsy them to determine more about that mass and what is its composition. So we don't just jump right in. A lot of times I get the question from a patient, how come you can't just do this right now? And there are several reasons why, and one of them is billing. But it's also that in order to perform this procedure, there is a certain amount of preparation that goes into the procedure. So usually we call you the next day, we get you an appointment, and during that time, you come up with questions, and those questions can often be answered by the nurse when you speak to her. And it's best to just write them down, because once you're talking to me or the nurse, you forgot everything you wanted to ask. So write your questions down. Prior to the procedure, you'll meet the radiologist, and then you can ask more questions. And we're going to keep repeating ourselves over and over again so that you understand the full extent of the risk of the procedure and what you're getting yourself into. The good news is that 80% of our biopsies are benign. No fasting required, but you must take your blood pressure medicine. We've had to cancel so many procedures because the patient did not take their blood pressure medicine and their blood pressure was through the roof, and that's not a safe situation for the patient. We often get questions about blood thinners. There's a long list of blood thinners, and we have a chart that helps us navigate through that process. But at the end of the day, whether you're on or off blood thinners, we're still going to do the biopsy. It's understandable. You're anxious. Some people take anxiety medicines every day. That's perfectly fine. But we recommend and require by hospital policy that you do not take any anxiety medicines until the consent is complete. You're going to typically have about a 1-hour appointment, and it's not a painless procedure, but it shouldn't be painful. Initially, you'll have some numbing medicine that stings, and after that, it shouldn't be painful. If it is, we need to make an adjustment. This picture here that you're seeing, this is a stereotactic breast biopsy. And this is, this is what you're doing. You're laying on a table and your breast goes through this hole. The machine is holding your breast still. And then we proceed with the biopsy, which requires us to numb up the skin. You usually have a little incision in the skin, but no stitches. And then the needle goes into the breast. Here's an example of an ultrasound guided biopsy. We try to choose the modality that best demonstrates the lesion. If it's best seen on a mammogram, then we go for stereotactic. If it's best seen on ultrasound, we like to use ultrasound guidance. This is certainly the most comfortable one because you're laying on your back and your breast isn't being compressed during the procedure. It's like I said, it shouldn't be painful, but you're going to feel something. If the only way we are able to detect the lesion is by MRI, then fortunately, we have a very efficient way of getting in there using the MRI to guide the needle into the breast. And this is what it looks like. You're laying on your stomach, your face is in this pillow, and your breast is being compressed by this grid. The machine then calculates the exact location for the needle placement, and then we take a sample. Just like all the other procedures, it's very similar, a little incision, and the tissue comes out. And at the end of every procedure, we leave a little metallic marker about the size of a grain of rice in that tissue. And when it's all over, regardless of how you had the procedure done, you're going to get a mammogram picture to show the marker placement. And that's very useful for future reference, whether it's benign or malignant. The thing we're trying to help you avoid is a surgical biopsy. Dr. Staren's not gone now, so so this is the thing we're trying to keep you away from. But sometimes this is what is necessary, and a very, very, very small percentage of situations. That's the only option for the patient. However, prior to surgery, you may come back to us, and what we'll do is localize that tumor in the radiology department and the breast imaging center, and send you off to the surgeon for your definitive surgery when that time comes. So you've had your biopsy, everything went well, and you're gonna, what do I do now? Well, now you have to wait. You're nervous, you're anxious. It's completely understandable. But first you have to make sure there are no complications, and that's going to be fairly easy as long as you follow the instructions that you get from the nurse for the wound care and activity. So you're going to have limited activity. It's a tiny, tiny little nick in the skin. So wound care should be pretty straightforward. You'll be instructed to wear a sports bra for a short period of time, and you'll be back to playing pickleball in just a few days. You don't have to read all this, but after about 3 to 5 days, we're going to call you and tell you what your results are. It's the most efficient way. You don't want to wait any longer. You don't want to have to come in just to hear that. And like most of the time, it's benign, but it's a whole lot of other stuff as well. It could be malignant, but it could be a lot of stuff in between benign and malignant. And some of those things require surgery, even if it's not malignant. Fortunately, in most cases, all of your care can be provided here at Eisenhower. We have this nurse navigator, which is fantastic that we have that. And our staff is really great. I mean, everybody plays a role, and whenever you have questions, somebody will be there to answer your questions. More broadly, the Cancer Center has counseling and support services. You've met Allie. She is just a goddess of resources. So thank you for your attention, and we'll open it up for questions. Oh, we got one more thing with Danielle. She has words.
Okay, so you've heard about screening, you've heard about diagnostic, you've heard about procedures, but what about where to have this done at? So I'm going to give you some information based on where to have it done. So here in Rancho Mirage, we have the Schnitzer Novak Breast Center, where we do screening mammography, bone density, diagnostic mammography, breast ultrasound, and breast procedures. The good thing is for screening mammography, we just updated our hours so that we are open from 7 a.m. until 6 p.m. So you can come in as early as 7:15 for your screening mammogram for you early risers. Or if you're still working, you can come at 5:30 and have your mammogram after work. So whatever is convenient for you, we try to offer something for everybody. Our diagnostics, we do from 8 a.m. to 3:30, right there in the middle of the day. That gives you time in the morning or in the afternoon to rest and recover from a procedure that you had. Here at La Quinta, we also have the Schnitzer Novak Breast Center where they do, again, screening mammography, bone density, diagnostics, and breast ultrasound. And they are open Monday through Friday from 7:30 to 4. We have a lot of days available at the Arduous Center for diagnostic and ultrasound. We don't do them every day there, but usually anymore, it's been 3 to 4 days a week. And then our newest location in Palm Springs. So this facility we opened in January, and there right now we're doing screening mammograms and bone density. But coming soon in summer of 2024, we're going to be doing diagnostic and ultrasound out there, thanks to our wonderful donors. And one of our radiologists will be out there at least to start 1 day a week to provide support to patients on the west end of the valley. So they are open 7:30 a.m. to 4 p.m. Tuesday and Thursday, and Wednesdays we have late hours at that location as well until 6 p.m. with your last one at 5:30. So that's all I have. Is there any questions for any of our radiologists, any of our staff, or myself that we can answer for you?
So, as Dr. Stern was mentioning, depending on the type of mastectomy you had and the amount of tissue that is left over, that's where the controversy starts, So if you have, some tissue left, that means there is a chance of turning to cancer in future. And depending on your risk, if you had a genes or a strong family history, you'll be at higher risk at that point as well. So your doctor might decide to do the ultrasound, as Dr. Sylvan suggested, or even MRI, because MRI is really good in terms of detecting any tiny cancers behind the implant, on the chest wall, recurrence in the lymph node. So it gives us a lot of information. So a lot of patients, like in your situation, actually, they may get MRI every other year or even every year in the beginning, or the other option, if they don't want to do any of them, they may do mammogram. As of now, on the surgery ward, the standard of care is actually just clinical exam. If on the clinical exam they don't feel anything and the surgeon does not feel you have enough tissue left, they may not recommend you doing anything, apart from annual exam or every 6 months exam. If you have tissue, and depending on the surgeon or oncologist you're seeing, they may or may not order the mammogram, ultrasound, or MRI, as mentioned. So it's very, controversial, this zone. Unfortunately, there's not enough data showing that which of these techniques are better, doing nothing exam versus very, very extreme imaging. Some of our patients actually get MRI every year and they get mammogram every year with bilateral mastectomy. It's very, very dependent on the patient and also on the physician, I would say. So these are the options you can discuss with your physician. And I would say if you are more of a warrior person, if you had a high risk, depending on other stuff, you can always ask them to start with either ultrasound or MRI every year, and then just change based on, your experience and as time goes by.
Okay.
So
Any information?
it's exactly in the same realm. And even with the flaps like that, there are even less data because there are less patients doing these kind of procedures. So again, would be very dependent on your doctor. But I always tell the patient, be advocate for yourself. If you're worried, try to get an answer. Waiting is not your answer. If you're more of a relaxed patient, some patients don't want to know more. They don't want to, they're not worried about it. So I would say, yeah, that's perfectly fine. But if you're worried, I would say, go and ask the question, get MRI, probably is going to be the best answer for you, and just take it from there.
Okay, thank you.
The guidelines are based on FDA. Actually, FDA in the past few years have recommended that patient with implants after 3 years, they have to get MRI because MRI is the best technique to evaluate the integrity of implant and also the rare problem that comes with the implant, which is called a kind of lymphoma that comes with implant rarely, but is a significant risk. So that's that for just screening aspect of a patient with implant, whether they have their breast tissue or they don't have a breast tissue after a mastectomy. But then in terms of the issues with implant, if you have pain or any changes in your implant, you can always start with mammogram and ultrasound. And if you have any concern, we always might get MRI because again, MRI is our gold standard for actually evaluating the implant as well.
Okay, if we don't have any other questions, we're going to conclude for the night. I do want to remind you that you guys all have a survey. If you could please fill out your survey before you leave, and you can either hand it to Cheryl or leave it on the back desk there. As always, just know that here at Eisenhower Health and within the Breast Center, we are here for you for your screening and diagnostic needs for mammography procedures, breast ultrasound. Again, as I said in the beginning, you're not in this alone. You have an excellent team there with you. So I thank you again for coming, and I hope that you all have got a small takeaway from the presentation tonight.